All right, hey everyone, welcome back. Let's jump into it today. We're tackling a pretty big topic today, one that every orthopedic resident kind of sweats about, especially when those big exams are looming, and that's polytrauma.
Oh, yeah. It's a beast.
It is. So to help us unpack this beast, we're going to be using the Ortho Made Simple notes. You can find them on the website, mokyingren.sg.
Awesome resource.
Yeah, really great stuff. And these notes were put together by Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore, and he aced his FRCS back in 2022.
Yeah, those notes are gold, especially for anyone gearing up for the FRCS or, any of those equivalent postgraduate exams.
For sure. So let's set the stage here. Imagine you're on call, and a 25-year-old comes in after, I don't know, maybe a motorcycle accident. Their heart's racing, they're breathing fast, temperature sky high. It's more than just a broken bone, right?
Oh, absolutely. That's the body going into full-on panic mode. We're talking systemic inflammatory response syndrome, or SIRS for short.
SIRS. Okay, so what's actually happening in the body when that SIRS alarm is going off?
Well, basically, it's like the body is flooding itself with all these chemical messengers. Think interleukins, TNF, alpha, the whole gang. They're trying to, contain the damage, kickstart the healing process.
Right, like an internal 911 call.
Exactly. But here's the catch. Too much of a good thing can be bad news. If that inflammatory response gets out of control, it's like a wildfire,
Okay.
And that's when we start seeing things like ARDS, MODS, potentially life-threatening stuff.
So it's not just about fixing the fractures. It's about managing this huge inflammatory response.
You got it. And then, of course, you have the lethal triad to worry about.
Yeah, the lethal triad. Why is this trio so dangerous?
Well, you've got hypothermia, hypercoagulopathy, and metabolic acidosis. It's a nasty cycle where each one makes the others worse. Like, let's say the patient's temperature drops way down hypothermia. That can mess with their clotting, leading to more bleeding hypercoagulopathy. And then you throw in metabolic acidosis, and suddenly their pH is all over the place. It's a recipe for disaster.
Got it. So we've got this patient, they're dealing with SIRS, we're watching out for the lethal triad. Now, what about their orthopedic injuries? Our instinct might be to jump in and fix everything right away, right? Isn't that what really total care or ETC is all about?
Well, it sounds good in theory, but sometimes rushing into these big, complex surgeries when the body is already overwhelmed can actually backfire.
Really? How so?
Think about it. Surgery itself is a trauma to the body. It can trigger more inflammation, more stress on an already struggling system. We call this the second hit phenomenon.
Oh, I see. So it's like adding fuel to the fire.
Yeah, precisely. And that's where damage control orthopedics, or DCO, comes in.
DCO. So what's the philosophy behind that?
DCO is all about stabilizing the patient, buying them some time for their body to recover before we go in and do those bigger reconstructive surgeries. Think of it like keeping a damaged ship afloat rather than trying to rebuild it in the middle of a storm.
Okay, so instead of rushing to definitively fix every fracture, we're focused on damage control, getting that inflammation under control.
Exactly. A lot of the research on DCO focuses on femoral shaft fractures. They're notorious for causing a ton of blood loss and really throwing a wrench into the system.
Makes sense. So if you see a question about DCO on your exam, think femur and stabilize.
Exactly. Now, there's also this newer approach called early appropriate care, or EAC, and it tries to find that sweet spot between ETC and DCO.
Early appropriate care, EAC. So how does that one work?
Well, with EAC, we're aiming for definitive fixation, but we're also really paying attention to the patient's physiological response before we dive into those big surgeries.
So it's kind of like a wait-and-see approach, but with a deadline.
Yeah, you could say that. The magic number here is 36 hours. We're monitoring things like lactate, pH, base excess. Basically, we're checking the vital signs at the cellular level. And if things are looking good after 36 hours, it means the patient is recovering well and can probably handle the stress of a more definitive surgery. But if those numbers are still off, then DCO is probably the safer bet.
So EAC is about finding that balance between timely intervention and avoiding that second hit. This is starting to come together. But before we go any further, let's just take a second to recap what we've learned so far. We're using those great Ortho Made Simple notes from mokyingren.sg to guide us through this whole thing.
Yeah, good idea. Let's make sure we're all on the same page. Okay, so we've talked about how the body reacts to trauma and the different ways we can manage these really complex polytrauma patients. But let's get into some specifics now. One thing that always seems to trip people up on exams is actually defining polytrauma itself.
Yeah, it's easy to get caught up in all the different injuries and forget about the actual criteria for diagnosing it. So how do we define polytrauma, especially for the exam?
The New Berlin classification, that's the key. It combines the severity of injuries in different parts of the body with the patient's overall physiological status.
So it's not just about the number of broken bones, but how well the body is handling the whole situation.
Exactly. The New Berlin classification uses the Abbreviated Injury Scale, or AIS, to score the severity of injuries in 9 different body regions. To have polytrauma, the patient needs an AI score of 3 or more in at least 2 different regions.
Okay, so we're talking serious injuries in multiple areas,
Yeah.
but you mentioned physiological parameters too. What are we looking for there?
Right, so on top of those AIS scores, you also need at least one of 5 physiological red flags. Either a systolic blood pressure less than 90, a Glasgow Coma Scale score less than 8, a base excess less than 96, an INR greater than 1.4, or a partial thromboplastin time greater than 40 seconds, or the patient being older than 70.
Wow, that's quite a checklist. It shows how complex these cases can be.
Absolutely. And then there's the Injury Severity Score, or ISS. It ranges from 0 to 75, and it's calculated by squaring the AI scores of the 3 most injured body regions.
So the higher the ISS, the worse the situation. But how does this score help us define polytrauma specifically?
Well, that's where things get a little tricky. There's no one agreed upon ISS value for defining polytrauma. You might see different thresholds used in different studies, like 15, 16, 18, even 25. So it's good to be aware of those different numbers when you're studying.
Got it. So the main takeaway is that polytrauma involves severe injuries across multiple body systems and significant physiological instability.
Exactly. Now let's talk about a really important treatment for polytrauma tranexamic acid, or TXA. You've probably heard of it.
Oh yeah, TXA. It's everywhere these days. But I'm still a little fuzzy on why it's so important in polytrauma.
Well, TXA is an antifibrinolytic, so it stops blood clots from breaking down. And in polytrauma, where bleeding can be a huge problem, TXA can really make a difference.
So it's like it strengthens the blood clots, making them less likely to dissolve.
Exactly. There's a lot of research to support this, too. The SOAR-2 trial showed that giving TXA within 3 hours of injury significantly reduces the risk of death from bleeding.
Wow, that's a big deal. So timing is crucial.
It is. That 3-hour window is key. Give it too late, and it might not help or could even cause problems.
Got it. Early TXA is crucial. What about the dosage? Is there a standard protocol?
Yes, definitely memorize this for your exams. The standard dose is a 1-gram loading dose over 10 minutes, then a 1-gram infusion over 8 hours.
Okay, so early and appropriate TXA administration check.
Yeah.
What else do we need to keep in mind when we're managing these complex polytrauma patients?
Well, the Advanced Trauma Life Support Protocol, or ATLS, is always our foundation for any critically injured patient. But with polytrauma, there are a few extra things we need to consider.
Right, ATLS is like our trauma Bible.
Hmm.
How does it apply specifically to polytrauma?
One key concept is the Massive Transfusion Protocol, or MTP. Because these patients are at such a high risk of massive bleeding, we have to be ready to replace blood components quickly and efficiently. The MTP typically uses a 1.1.1 ratio of packed red cells, plasma, and platelets.
All right, so we're not just replenishing volume, we're also making sure they have the clotting factors they need. What other pearls of wisdom do we need for polytrauma?
Well, sometimes less is more. There's this idea called permissive hypotension, where we allow the blood pressure to stay a little lower than usual, just enough to keep the organs working.
Wait, permissive hypotension. Isn't it always critical to keep blood pressure up in trauma?
Normally, yes. But when there's active bleeding in polytrauma, giving too many fluids can actually make things worse. It can dilute the clotting factors and even disrupt clot formation.
So it's about finding a balance between maintaining circulation and letting the body's natural clotting process work.
Exactly. And don't forget about the different classes of shock. You'll need to know those for your exams. Remember, Class 1 is basically normal vital signs. Class 2 adds tachycardia. Class 3 brings in hypotension. And Class 4, the worst one, includes altered mental status and low urine output. That's when things are really serious.
Okay, so recognizing the class of shock helps us decide how to manage the patient. We've really gotten into the details of polytrauma now. One more thing we should discuss is fat embolism. It's a common exam question, and it can be a serious complication, especially with those high-energy fractures we often see in polytrauma.
Yeah, for sure. We definitely need to be aware of it, especially in the first few days after the injury.
Right, fat embolism. But I always get a bit confused about the diagnostic criteria. Can you remind us what to look for?
Gert's criteria is what we use to diagnose fat embolism. It includes major and minor criteria. The major criteria are the big ones. respiratory insufficiency, central nervous system depression that's out of proportion to the hypoxemia, and pulmonary edema.
Okay, so respiratory distress, neurological changes, and fluid in the lungs. What about the minor criteria?
The minor criteria are like supporting evidence, things like tachycardia, fever, petechiae, fat in the urine or sputum, and a sudden drop in hemoglobin or platelet count.
So we need to consider all these factors together. But what's the good news here? How do we treat fat embolism?
The good news is that it's usually self-limiting. Most of the time, all we need is supportive care, helping them breathe if they need it, making sure they have enough oxygen, and managing other symptoms as they come up.
So it's about keeping them stable and letting their body recover. Wow, we've covered a lot here, from those scoring systems to TXA and even fat embolism. Those ortho-made simple notes from mokyingren.sg have been really helpful.
They really have. Dr. Mok has done a great job putting all this information together.
All right, so we've really gone deep into polytrauma here, haven't we? We've covered so much, from that initial inflammatory response to those tough treatment choices.
Yeah, it's been quite the journey, but like any good climb, I think it's good to stop, catch our breath, and make sure we've got all the essentials packed away, before we head back down.
Absolutely. So let's recap those key takeaways, those must-know points that will help us crush those exam questions and, even more importantly, take great care of our polytrauma patients.
Sounds like a plan.
Okay, so first and foremost, polytrauma is not just about fixing broken bones. It's this whole-body physiological crisis that sets off a huge inflammatory response, that SIRS cascade we talked about.
Right, SIRS, or systemic inflammatory response syndrome. And if that gets out of control, it can lead to some pretty serious complications like ARDs and ABAs.
Exactly. And then we have that, that dangerous trio, that lethal triad always lurking in the background: hypothermia, hypercoagulopathy, and metabolic acidosis. They can really wreak havoc.
Yeah, it's a vicious cycle. One problem just feeds into the next.
We also talked about how our thinking on managing polytrauma has evolved, right? It's
Yeah.
moved away from that "let's fix everything right now" approach of early total care, and we're now thinking more about damage control orthopedics and early appropriate care.
Yeah, it's really interesting how our understanding of the body's response to trauma has changed the way we approach treatment. We're looking at the bigger picture now, not just the orthopedic injuries themselves.
Right. It's about finding that balance, intervening at the right time without overwhelming the system. And speaking of intervention, we can't forget about tranexamic acid, TXA. That's such a crucial medication in these cases. It can really make a difference in reducing mortality from bleeding, especially if we give it early enough.
Absolutely. TXA is a game changer, but that 3-hour window is so important. Time is really of the essence there.
And we have those other important tools too, like ATLS, massive transfusion protocols, and even that idea of permissive hypotension, which can be a little counterintuitive at first.
Yeah, each one has its own role to play in stabilizing these patients and helping them recover.
We also got into the details of fat embolism, which can be a tricky diagnosis. Remembering GERD's criteria, those major and minor signs, is really helpful there.
For sure. It's like detective work, putting all those clues together. But the good news is that most cases resolve on their own with just supportive care.
So it's about staying vigilant and being ready to provide the right support. Well, I think we've summited Mount Polytrauma here, and those ortho-made simple notes from mokyingren.sg have been an awesome guide.
They really have. Dr. Mok has put together an amazing resource for anyone studying for these exams.
Absolutely. But before we sign off, I want to leave you with one last thought. As you continue to study and start seeing more polytrauma cases, think about how that concept of the second hit impacts our surgical decisions. Would the timing of definitive fixation be different for someone with just orthopedic injuries versus someone who also has, say, severe chest or abdominal trauma? It's something to consider as you move forward in your training.
That's a great point. There's no one-size-fits-all approach to polytrauma.
All right, well, on that note, I think we've reached the top of our polytrauma deep dive. Thanks for joining us.
It's been a pleasure.
And to all our fellow orthopedic residents out there, keep pushing yourselves, keep learning, and remember, the view from the top is worth the climb.